A very good morning to all of you, and welcome to this course on posterior capsule rupture management. Thank you for being here on the last day of the course. We are starting the program a little late, but we will still go on with the entire 75-minute schedule. So I have with me some stellar faculty. We have on the first talk Dr. Minu Mathin, an exemplary surgeon who's from Trivandrum, who will be sharing the first topic on nucleus management and how to convert to SICS. This will be followed by Dr. Sujata Mohan, a very distinguished, renowned surgeon from Rajan Eye Care in Chennai, and she'll be talking to us about the anterior vitrectomy techniques. This will be followed by Dr. Shivakumar, who heads the cataract services at Aravind, Tirunelveli, and he will be talking about how do we remove the cortex when you have a posterior capsule rupture. He's a very well known for his training of the residents and fellows. So following this, I'll be sharing the different tips on IOL placement in eyes with posterior capsule rupture when you have at least some of the support. Dr. Vivekanandan, who is from Aravind Hospital, Pondicherry, will then be sharing some new techniques on how do you fix the IOL to the iris in case you don't have capsular support. And Dr. Prabhu Bhaskaran, who is an innovator and a very accomplished vitreoretinal surgeon, will be sharing his technique of doing a scleral fixated IOL. So I'd like to invite Dr. Minu Mathin to deliver his first talk.
Thank you, Dr. Haripriya. Good morning, ladies and gentlemen. Let's straight go into the topic of nucleus management in PC rupture. No financial interest in this. So when you have a PC rupture, you can have it as early as this, even before starting your phaco. So hydro rupture of the PC itself can cause a PC rupture and then a nucleus drop immediately before you start. That is the most dreaded thing. We would like to avoid such a thing. So we should take clues from what is happening. See, when I'm rotating this, see that line there. That's a subtle line which you have to notice on the posterior capsule, which doesn't change shape. That means there is something behind the nucleus, which is most probably a posterior capsule rupture. But the pupil is slightly small. There is no vitreous. So this is in 2011, as you can see, done in 2011, when I am much younger and much bolder than what I am now. So I am just going ahead with the phaco, but the movements are controlled, but I have not changed any settings. I think that is the wrong thing which we do when we are bolder. So things should happen away from the area of the capsular rupture, and also it should happen slowly, and your flow rate should come down, and the vacuum should be used minimally. Here again, things are going very slow. It is being done away from the area of rupture, especially in the anterior chamber, and I am lucky that nothing fell down through the open capsule. So it is very much possible. So here, if you notice, look at this piece of nucleus. This is half of nucleus here, this side. It is almost disappearing in the pupillar area. That means there is some posterior capsule rupture behind. So I stop and wait and don't take out the irrigation or your phaco probe. That is the first thing to do. And fill up and push down the capsule or the vitreous if it has come up with dispersive viscoelastic. Here there is no vitreous. So with the dispersive viscoelastic there, I reduce my vacuum and most importantly reduce my flow rate and do most of the phaco without multiple sub-chops, because if you sub-chop into very small pieces, they tend to float around and drop through large posterior capsule openings. So I eat up the whole piece gradually and slowly, and now comes up the central opening, which you can see very clearly here, posterior polar cataracts, which may hide behind mature cataracts like this. Especially in India, we have so many patients coming like this. So these kind of linear line extending from one end to the other is mostly a posterior polar cataract, which would give way when we do this initial chopping. So now I bring out the half of the nucleus into the anterior chamber, get a 3-piece IOL. You can put it on top of the iris if you are not sure of the anterior rexus margin, or if you are sure that the rexus margin is there, you can place it into the sulcus itself. Now one of my haptics is on the iris. After that, this emulsification of the rest of the nucleus under viscoat protection of the endothelium, and very slowly. And you can notice that I am not splitting it very widely, and small chops, very small, mild separation, and then trying to eat off most of the lens part by part, not letting it go up. And you can notice that the IOL is acting like a scaffold, and it is preventing any nucleus piece from going down. That is the purpose of having the lens there, the IOL there. And here again, very gently, the movements are all very gentle, very slow, take your time, and then finish off piece by piece and complete. And again, do not take out anything without putting in viscoelastics. And I now dilate the pupil. Mostly the pupil will come down when the nucleus is being taken into the anterior chamber. Dilate it and visualize and do a vitrectomy, because I have put in a lot of visco behind and it has gone into the vitreous. And to take out that, it is difficult without disturbing the vitreous, and so I do a vitrectomy along with the aspiration of because HPMC, once it goes into the vitreous and mixes, it causes a lot of glaucoma and inflammation later. And the IOL goes into the sulcus, and it is barely captured because the rexus size is slightly larger in these kind of cases. And the good thing is that the IOL is well centered and you won't get a PCO later to YAG. So here again, in a mature cataract, my rexus is complete. Just to show you that rexus is complete, I do my first job, see the central white area there, and I see something fluttering here. This is a very clear area. Generally you don't see something like this. You'll have some vitreous. Now this line which I am touching, that is proven that by touching it I can touch the posterior capsule. There's a large opening in the posterior capsule. So the whole lens is there, divided into two definitely, but more pieces are still there. So here I would not want to continue on phaco. So decide prudently when you want to convert. Here I am trying to extend my corneal incision, not the ideal thing to do, but to 4 millimeters, so that this can be taken out. So here you can notice they have been already subdivided. So they are coming piece by piece. So viscoat has been injected to the into the anterior vitreous, and that is protecting the lens pieces from falling down. But here it is always good. Instead of an IOL, you can have this kind of a silicon slide. This is the sheets glide which we have forgotten, but still it can be made out of this silicon bands, and it can be placed underneath so that it doesn't drop while you are trying to take it out with the vectors, or we can hold it with a large forceps also, and it can be pulled out. So once these nucleus bits are out, then we can suture this opening which we have created larger on the cornea, and then go ahead with anterior vitrectomy. The details of anterior vitrectomy will be covered in a different topic. And once the anterior vitrectomy is done, we make sure that the vitreous is fully gone and the lens goes into the sulcus where the rexus margin is intact. And here the rexus is too large to capture, but it doesn't matter. Even if it is not captured, it doesn't matter. Some of the lenses now with 13.5 millimeter overall size is well fit into the, and this is the last case, but done by a trainee. This is a little difficult to see, but then please watch, the rexus is very small. So do a forceful hydro, you can see a pupillary snap already. And now further hydrodissection is happening without realizing. And now you can see a very clear area, and now the rotation of the nucleus stops. So you push, it goes to one side, doesn't spring back. So now we take over and dilate the pupil. That's the first thing to do. And the rexus is small, so we extend the rexus. As far as possible, retain an intact rexus margin. And this nucleus is full nucleus. So it is tilting, but when you try to dial it out with viscoat going underneath the lens, it's okay. So you can dial the nucleus out into the anterior chamber. I have extended a little bit, but now you can, option is yours. You can go to a different location, create a good corneoscleral tunnel, or you can give back cuts after doing a localized peritomy, back cuts from the edges of your clear corneal incision and make a large sclerocorneal tunnel. So there is no compromise on the size of the tunnel here, because the nucleus is very large and you need to take it out cleanly without manipulating in the anterior chamber more. So and at least a 7 to 8 millimeter internal opening is required to get this very hard cataract out, and without irrigating much it is delivered out, and now luckily it comes out in one piece. And now the incision is sutured, and then we go ahead like what we saw before, put the iris hooks back again, visualize what is there. Is there a capsule rupture, anterior capsule rexus margin rupture? If not, you can continue the vitrectomy and place the IOL in the sulcus and have outcomes as good as a regular normal case. So recognition early and the decision to convert, if you are in doubt to proceed with phaco, will give you best results even in a PC rupture early happening in phacoemulsification. Thank you very much.
Thank you very much, sir, and I know you're hard pressed for time as you have another course running simultaneously. So thank you very much. I now invite Dr. Sujata Mohan of Rajat Care to talk about the principles and how to do an anterior vitrectomy.
Can you switch over to this? AV people? Hello? Is anybody there? Can you switch? Okay, thank you. So good morning, everybody. At the outset, I'd like to thank Dr. Haripriya for calling me for this course once again. And my topic is going to be on vitrectomy principles for the anterior segment surgeon. So the key components in the management of vitreous loss in PCR are early and quick recognition, which she already showed, avoidance of hypotony, maintenance of a closed anterior chamber, prevention of PCR extension, prevention of nucleus drop, prevention of vitreous traction, and ultimately IOL implantation. So how do you recognize an early PCR? There is a sudden deepening of the anterior chamber, there is a tilt of the IOL, and what you can see is a very subtle pupillary snap sign. So in which case, don't panic, avoid withdrawal of the phaco probe, maintain the foot better in irrigation position, insert a dispersive OVD through the side port, and withdraw the phaco probe once the AC is formed. So this is a classic case of what not to do, because this was done by a trainee. You can see this was done in 2007. And already there's a PCR and he has not noticed it. There's a nucleus drop as well, and he's continuing to go ahead with his infusion aspiration, and you can suddenly now he'll realize what's going on, and then he's going to pull out. You see, once he pulls out, there's a very large widening of the PCR. So this is exactly what you should not do. So do not shallow the anterior chamber, whereas the same PCR is being handled by a senior surgeon. The surgeon has noticed a small PCR, so now he has reduced all the parameters, lowered the bottle height, reduced his phacos. He is going in for a slow motion phaco and removing the very, very small bits very slowly without causing an extension of the PCR. And most importantly, you notice after he has finished removing the nucleus bits, he is going to come out and inject the OVD to cover close the defect before pulling out his phaco probe. So that is the key. So don't immediately pull out your irrigation. Make sure anterior chamber is deep and insert an OVD. So this is a diagrammatic representation showing how you can insert an OVD even in the presence of nucleus bits. Try to go and plug the hole so that the nucleus bit floats up, and Dr. Minu showed such lovely examples of how you can convert even after a PCR. So this is again, you can do a controlled phacoemulsification with the small nuclear fragments. If you're not comfortable with it, you can use viscoelastic to remove the small bits, because removing nuclear fragments which are very small can be very difficult, and so and sometimes they can fall in. So the most important thing is to plug the opening. So the next thing you do is, once you have found out there is vitreous, you convert into bimanual anterior vitrectomy. Don't go ahead with your coaxial. So AC maintainer with the flow directed towards the angle, new side port for sleeveless vitrectomy cutters, lower the bottle height, and most importantly, use the highest cut rate the machine offers. So suction has to be low, your vacuum has to be low, but the cutting rate has to be high. And use triamcinolone to stain the vitreous. The vitrector is placed just below the tear towards the optic nerve. The vitreous cutter is maintained centrally and not moved peripherally. So you cut and move forward, you cut and move forward. Don't drag the vitreous. If you drag the vitreous, then you are likely to cause genital tears. So this is a classic example of what you can do. In spite of the fact, you see there is a PCR and we have already converted to bimanual method, and there is an infusion and aspiration going on. So we have switched, so you can do that. You can, every time you come out, you inject viscoelastic and then you come out. See, in spite of using bimanual, you can see that the PCR is extending. So that this step, at this point of time, there is a vitreous loss as well. So you will have to start doing a vitrectomy. So it has to be a bimanual vitrectomy, and what you can do is to prevent further worsening of the opening. you inject some viscoelastic and do vitrectomy cutting. You can use the same vitrectomy cutter to aspirate also. Once you've removed all the vitreous, you can do that. Don't aspirate in the presence of vitreous. So once you've done that, now the next, now so you're completely cleared, you can inject an IOL and do a pupil capture, optic capture, just like what Dr. Menu showed. So that is very important. This is again another case where there's a very small PCR which has been noticed by the surgeon. And so immediately, so what's happening? He has kept his phaco port inside, and you can see the very small PCR here, and he has converted into bimanual. Now for the aspiration, he is doing aspirating the cortex to become bimanual aspiration is going on, and injecting the viscoelastic. You can, it's a very small PCR, so you can even go ahead and put a single piece IOL in the bag. So the most, see at the end of the case, you can see that the PCR is not extended. That is the most important thing. So vitreous management is very important. Triamcinolone should be used to stain the vitreous. Avoid using cellulose sponge vitrectomy. Don't sweep the wound with a spatula. Anti-vitreous traction can cause a pull on the vitreous base and anterior retina, which can lead to GRT. And vitreous cutters should be used to cut the vitreous even in the wound. So this is again a case of PCR where the vitreous has been stained and bimanual vitrectomy is being used, and you can see the vitreous cutter is used to remove all the vitreous remnants which are being stained, and you can see some amount of vitreous remnants in the wound as well, which is going to be removed with a vitrectomy cutter. And see, as you're removing the cortex, sometimes the vitreous will present, in which case you have to stop, convert again into vitrectomy, and the vitreous from the wound, you should be cut, should not be pulled. You can see that I'm cutting it as I'm pulling it forward. So that is the most important thing, a lesson to learn in this. So how to avoid posterior vitreous traction? Fast cutting rate, low suction, low flow rates, keep the cutter stationary, and advance slowly forwards as the vitreous is cut. Do not pull out when the vacuum is on, and the cutter tip should always be visible. So you have to understand that the vitreous acts like a slinky. So as soon as the vitreous loss, it continues to prolapse. If it's a very small prolapse, you can just continue with your anti-vitrectomy. But if you have a very large prolapse, you have to do a pars plana vitrectomy. And this, I'll just show you a case of how, this is a diagrammatic representation showing how a pars plana vitrectomy removes the vitreous much better than doing an anterior vitrectomy. So in this case, the patient had an IOL already implanted, but you can see that this continuous vitreous prolapse coming out. So I'm making inserting through the pars plana, I'm introducing a trocar, and through the trocar and cannula, we're doing a bimanual vitrectomy and removing the vitreous. The advantage with this method is the vitreous gets cut off from the way from where it gets prolapsed. Whereas if you do an anterior vitrectomy at this point, it continues to prolapse. You may cut, but more will come, more will come. So when you go from the bottom and you cut off the vitreous, then it falls backward, and you're able to completely clear the vitreous. So this is the last case I'm going to show. This is a very small, very normal case. You can see a slightly smaller pupil, but very soft cataract. I didn't expect much to go wrong with this case. And I mean, it's always important, whatever stage in your life you're in, you should always be aware that each case is different, and you have to be aware of what you're doing. So this is, it's a very grade 2 cataract. And you can see now I've just made one division. And now see how far I'm going in. See, this is a mistake I've made. This is a place where I've gone too deep, and you can see already see the PCR there. So I also noticed the PCR. So what I did, so I decided to just bring out all the nuclear, because it was a small cataract, we were able to bring it out and keep it out. And then I'm using a bimanual anterior bimanual IA for removing the small bits. Because it's a soft cataract, we can go ahead and do that. And once you have done that and removed all the vitreous, all the cortical, all the nucleus matter, now what I'm going to do is I'm also doing an IA to remove as much of the cortex as possible. You can see the PCR is extended quite significantly. So now I'm going to put a lens just like what Dr. Minu showed, so, and use it as a scaffold to remove the rest of the pieces. The most important thing here is to prevent the pieces from falling. You have already removed all the cortex, and the bag is clean now. So I'm injecting a multi-piece IOL. I put it on top of the iris. You can put it on top of the iris, or alternatively, like what I'm doing now is I'm inserting it into the sulcus. Just make sure that you don't put it you put it on top of the sulcus and not inside the eye. So once you've done that, then you can go ahead and do the phaco and remove all the components of the residual nucleus bits. So to summarize, always go bimanual. Once you have PCR and you know there's going to be vitreous loss, go bimanual. Stain the vitreous is very important because that becomes the order of the day today. Use a higher cut rate, very important to use a high cut rate during vitrectomy and low vacuum. And in cases where there is continuous vitreous prolapse, do a pars plana vitrectomy. Thank you.
Thank you, ma'am. Let's proceed with the next talk. So after the talks on the principles of vitrectomy and the nucleus removal, I'm very grateful to Haripriya madam for this opportunity to talk about cortex wash in the presence of PCR. I'm very grateful to Haripriya madam and Dr. Madhushekar and Dr. Vivekanandan for sharing their videos. So we know that capsular complications preempt the placement of IOL in the bag, which is the ideal position. And among the capsular complications, posterior capsular rupture is the most common. And early recognition and minimizing damage gives better outcomes, as we see. But at whatever stage the PCR occurs, the remaining steps have to be carried out. So whether it is during nucleus management or cortex wash or later, this has to be carried out interspersed with vitrectomy whenever vitreous intervenes. And simultaneously, we need to take care that lens matter does not luxate into the vitreous when we are doing these steps. So a challenging situation arises when a PCR is detected with all or some significant cortex remaining, and the surgeon usually is a little deterred by this condition. But on the flip side, we have to remember that wherever there is cortex, there is a PC, and the surgeon should take heart that he still has some support to place the IOL. So what would be the problems of cortex in the presence of a PCR? Ideally, it needs a thorough cortical removal. So we should be removing out 100% cortex. There can be an enlargement of the PCR on repeated attempts or repeated collapse of the chamber during the process, or it could be because of some wrong techniques like pulling on the PCR. Cortex removal may become more difficult when vitreous presents, and instead vitreous may be aspirated. And in turn, this leads to causing traction on the retina, which can lead to immediate to even late post-operative complications. And during this process, the cortex may drop into the vitreous. So we look at some of the videos where we'll see some of the principles of cortical wash. So here I am not still sure, it's an opening which I see, it's a PPC. So what I'm doing is I'm stripping off the cortex. I'm still using the coaxial IA, and while I am doing this, I notice that there is a line which I see here to my right, and once I decide that there is a PCR in this case, I'm not stripping it past the center, but now I see the line, and once I see here you can see the line, so I fill the chamber with viscoelastics, and I'm more comfortable with making a new side port and using a dry Simcoe cortical aspiration in order to take the rest of it. Now this sort of ensures that I remove the cortex without breaking the anterior vitreous face. Coming to the dry cortex wash with Simcoe, when vitreous is already presented, we go ahead with the vitrectomy with the chamber filled with viscoelastic in this case. And then you have the entire cortex remaining, and with the Simcoe, we carefully hold the cortex and peel it off the PC. So what we have to take care is that the Simcoe aspiration port is completely plugged with cortex, especially when passing through the area of the PCR, so that it does not catch vitreous on the way. So you can see that this is being carefully done. better would always be to go for a retroillumination, which gives you a very good view. And the other principle that you should remember is that you take the cortex away from the area of the PCR, as you see here, and any decompression of the globe can lead to a sudden prolapse of the vitreous in between. So you can see here that after this piece, there's a bulge in the PC, you can see. I confirm it with the movement of the PC with the help of a spatula. So now it means that I need to do some vitrectomy. It isn't there, it is here. So I do a vitrectomy again and then proceed with removing the rest from the two corners of the PCR. So after ensuring that there is no more vitreous, I just go ahead and carefully peel it off, and so you can see the other end of the PCR. Now a little bit of the cortex in the periphery may or may not be problematic, but it's good if you can really get an access. Now the other principle is that you should always strip this towards the away from the towards the PCR, not away from it. So you can see that this last piece remaining, I can actually have I could have actually gone from the PC tear to the periphery, but I take pains to strip this final bit off and towards the PCR. So this explains majorly the principles that we need to follow. Whenever there is a large PCR with vitreous loss, you may not be able to see the cortex, but that doesn't mean it is not there. So we have to judge if any cortex is present after doing a vitrectomy. So once you do a vitrectomy, the cortex wash becomes easier, and then you will see that the PC also actually unfurls towards the center, and it's actually much smaller than what you initially saw. And if you can't have see the vitreous and the pupil is small, it will always be worthwhile to go with using the iris hooks to dilate the pupil, and then go ahead and remove the cortex from around the back. Whenever cortex intervenes, you know it, you are not able to get a hold on the cortex, and you see that it's immaturely getting, the vitreous is getting pulled. So at that stage, doing a vitrectomy will help in getting the cortex out better. So we saw cortex wash with the Simcoe and with the IA probe, and in which conditions we can do it. Here we will see it with the vitrectomy probe itself in the IA mode. Now this can be done whenever we are expecting that vitreous loss may happen or vitreous may present during the process of cortex wash. So here you can see that this surgeon used a 2500 cut in the cut IA mode. The vitrectomy has been done, and now the surgeon goes with the vitrectomy probe in the IA mode. Look, the cuts have been converted to 0. The surgeon is using it only in the aspiration position, and it's been carefully teased out, taking care that none of it gets dispersed into the central opening or into the vitreous. So this is being carefully done, and as I said, the advantage of this is you will now notice is when this is being done, in case vitreous presents itself, you can always stay inside, convert to cut IA mode, and then cut the vitreous and proceed with the rest. So here when you see this is being teased out, there is presentation of vitreous. The surgeon immediately reaches the area of the PCR, converts to the cut IA mode, and you can see it goes at 2500 cuts per minute. And after this vitrectomy, the remaining cortex will be removed. So what are the problems of residual cortex? One is that it can cause low grade to significant iritis, and the iritis may stay for a very prolonged time. If we leave behind some of the cortex, like the cortex that I showed in that second case, then that can opacify on the PC, and if it is in the pupillary area, it can obscure vision. So it may look as a transparent sheet when we are leaving it, but later opacification can cause problems. If there is a significant chunk of cortex in the periphery or on the PC, we need to undertake a resurgery for the cortex removal. And now this is more fraught with risks, because it increases the risks of endophthalmitis, and instability of the IOL is also possible, and you may need to use some other techniques like fixating it to the iris, which we will see later. And a residual cortex adjacent to the PCR can actually become more fluffy and can drop into the vitreous. And vitreous in the cortex in the vitreous can actually cause raised IOP, which can stay for a prolonged time, It can at the least cause floaters to the patient, and it can be very irritating, and it may cause prolonged inflammation. So it's always good to do a thoracocortical wash, be patient, and do it properly. To conclude, it requires skill and more so a good judgment about the extent and timing of the vitrectomy, when it is needed and how to remove the cortex. Ideal would be to remove all the cortex, but having said that, it is good to recognize when to leave it a bit if you feel that the PCR is likely to extend. In short, good management leads to good post-operative outcomes in the immediate post-operative period as well as in the long term. Thank you very much.
Thank you. That was, I think, a lot of good tips on how to remove cortex, and Dr. Shivakumar clearly explained why it is so important to remove the cortex completely and not to be in a hurry. Once you have a PC rent, we think of the nucleus and then the IOL. We don't give as much importance to the vitreous and cortex, so it's important that removing this cortex completely is very critical in getting a good outcome. With that, we go on to the next talk on IOL placement in eyes with posterior capsule rupture. Can we have the slides on, please? So in terms of what are the options we have for IOL placement, once you have a posterior capsule rupture with an intact rhexis and a small PC tear, one can think of placing the IOL in the bag also, especially if it's a punched out rhexis or rhexis in the center. But if it's a large rent, or if you have a rhexis tear and don't have adequate capsular support but a small PC tear, then one can think of sulcus placement. In case you don't have adequate anterior or posterior capsule support and the whole bag is extruded, then you will think of the iris fixation or sletal fixation technique. Capsular bag fixation, always a single piece IOL, much easier than placing a 3-piece in the bag. And sulcus placement, we never place a single piece, we only place a 3-piece in the sulcus. Before the IOL is placed, we have to clear the vitreous. All the lens matter has to be removed. That I think we have to remember that we should not be in a hurry to think of the lens only. That will come only based on how much of residual capsule support you have after you've removed all the lens matter and cleared the vitreous. Make sure you have good visibility. That's when you will be able to choose the right kind of lens. If you've already planned a specific lens like a multifocal or a toric, whether that can be placed or not, only after you've put iris hooks and able to see where the support is. And assess the anterior capsule rim, posterior capsule rim, and then decide if you want to go for an alternate technique as well. So these iris hooks are invaluable. I think in more than regular phaco, when you have a patient, almost always the pupil comes down. So use the iris hooks once the vitreous is removed. This way you lift the iris, so you have enough space in the sulcus to place the IOL comfortably. And the anterior capsule rim is also visible well. The sulcus always a 3-piece, and if you have noticed, the leading haptic of a 3-piece lens has to be, when loaded, has to be in a convex style. That way it will go comfortably into the sulcus, and that is the easiest way for you to place it. And the trailing haptic is then placed. So these hooks are very useful. Otherwise you may go and place the lens in the bag. You may think you're placing it in the sulcus, but this may go into the bag, in which case the IOL will decenter and even dislocate. Even if your pupil is not very small, like in patients who have a slightly larger pupil, if you're using a plunger for an injector, one can do this one-handed implantation. The other hand, use a Kuglin's hook and retract the iris. Again, you'll have to see where the haptic goes. We cannot blindly place the IOL like we would do if the PC was intact. So while implanting the leading or the trailing haptic, retract the iris with your Kuglin's hook or a Y hook, and then you place your IOL in the sulcus and optic capture. 3-piece IOLs, I mean, if you're placing it in the sulcus and you have the adequate size, if it's very large, of course you can't capture, but most phaco-rhexis you can capture the optic in the rhexis margin. In patients who have, like I said, this is just to show that a IOL was placed by mistake in the bag. If you don't take care, this is what can happen. It can decenter, it can dislocate. Now this is a 3-piece lens, so it's not being exchanged. Otherwise, if you're going to place it in the sulcus, and if it's a single piece, I would even plan to go and do an IOL exchange. Now PMMA haptic, though it's a single piece, the same lens is used in sulcus. Retract, like I showed in the earlier case, with your Kuglin's hook, and then dial your haptic into the sulcus, and that's how these IOLs will center well. This is a patient who had a posterior polar with a pre-existing posterior capsule rupture. So there's a high chance here, and there was a PCR earlier pre-op also noticed through an OCT. Lot of care is being done to kind of not enlarge the PC rent. So before the IA probe is retracted, you want to inject a dispersive viscoelastic. I would do this either if there was vitreous loss or no vitreous loss. This will help to contain the vitreous loss and prevent the PCR from extending larger. So you can see a central split in the PC because of the posterior capsular rent. IOL in the bag, single piece, ensure the leading haptic and optic junction. It is flexed so that can actually go into the bag without having to dial it. So it's not a good idea to dial these lenses into the bag, but you can just flex the haptic. That's why the single piece lenses are preferable when you're trying to place an IOL in the bag. You don't have to go and remove the viscoelastic behind the IOL in most instances. Now just I'm cleaning up the lens matter which is fibrosed at the edge of the PC tear here. But these lenses, you can either do a 3-piece in sulcus or a single piece in the bag. Especially if there's no vitreous loss, this can be an option. Now this is a patient with a PC rent. So once a rent is identified, the rest of the nucleus, just to show a step-by-step approach of this patient. So the goal here is to ensure the rent does not become larger. You do the phaco away from the area of the rent, try to stay away. Slow motion phaco, ensure good chamber stability, you have good fluidics, and then emulsify the cataract. So you'll have to have the fragments away from the rent area, and then I'm using the phaco probe, but I think it's preferable to go and use the IA probe in these cases to get the epinucleus out. That is a safer option. Once the nucleus and the cortex is removed, then you can go ahead and do the anterior vitrectomy. So the epinucleus is removed. For irrigation aspiration, like Dr. Shivakumar said, you can either go in with the Simcoe. If you're using the automated INA, you can go with a bimanual also. This way you can have the irrigation away from the area of the aspiration, so you can keep it away from the rent area, whereas the aspiration probe may have to go to the area of the rent. Now the vitrectomy is done after that, so the cutter is facing the vitreous. This way the vitreous will cut and go back home. So now you will have to remember that you will not have to have it so close that it cuts the PC, but trying to face it will help. I normally do wound assisted implantation, but I would never do it if I want to take an IOL in the bag for a PC rent patient. So because I want the haptic to go into the right place. So extend the incision, and like I said earlier, just flex the haptics and place it away from the area of rent. And the cortex is removed again very gently. You want to have a stable chamber, but don't overhydrate when removing the viscoelastic, I'm sorry. That is important. So like I said, the goal is to ensure that the rent which we had initially is not enlarged. Finally, I would like to use a pilocarpine as well, just to prevent any kind of vitreous prolapse in the post-op period and to check for any vitreous on the table as well. This is another case where I chose to do a capsular bag fixation, but this is a large rent. Again, before placing it, a vitrectomy is important. Here there is a large rent in the center, so you can have the cutter facing down, and you can see the capsule rim of the rent is straightened, which means the vitreous is pushed back. And once that is done, I would like to use the hooks. One, because I want to also enlarge the anticapsular axis, because it's a little larger PC rent. So there should be enough space to insinuate the IOL in the bag between the anterior and posterior capsule. So enlarge the enlarge the axis slightly. As mentioned earlier, enlarge the wound, take the IOL inside the bag. Leading haptic has to be stabilized on the rim of the capsule which is there. And look at, one does not have to use a single piece. So, but if you're placing a single piece, this will be the step-by-step approach. So make sure your axis is large enough, your vitreous is taken care of, you have good visibility, use the iris hooks, flex the haptics and place it. If you're placing it in the sulcus, ensure that your loading is done well, and again make it maybe 3.2. Some of these cartridges you need for a 3-piece lens are slightly larger than what you would use for a single-piece lens. So Dr. Vivekananda will be showing the iris fixation technique. I'll just show one variation of this technique of how one can consider doing an iris fixation with a 3-piece IOL. So this is a bag, capsular bag and IOL which is completely contracted in a patient who had retinitis pigmentosa. So through a 3 millimeter incision, the IOL is cut, and then a new 3-piece acrylic IOL is first placed in the anterior chamber. So this is a sensor IOL. I like a sensor in these cases because the anterior surface is rounded. So I'll only tile the leading haptic behind the iris, have the optic in the anterior chamber, supported from below using a cyclodialysis spatula, and tuck the trailing haptic below the iris. This way you have an optic capture. So this spatula on the left hand becomes very critical to hold it. And after this, fixation becomes easy. So you will probably see more ways of how you can tie it. So because of this capture, the haptic becomes more evident. You can see it well. Take a bite below it and then suture both the ends on both sides of the haptic. So in conclusion, early recognition of a PC tear is important, and choosing the right IOL design and placement can also ensure a good outcome in these patients. Thank you. I'd like to yes, Dr. Prabhu Bhaskaran to go on.
After listening to the previous talk, I don't know whether are we really needed Vivek and I. So anyway, if everything fails and you're not able to place an IOL, so we are here to help you out. Can you have the video? So I'm going to show two. I'm not able to see here. Yeah. So I'm going to show you two videos. This is case number 1. This is post small incision cataract surgery. AC maintenance is the first thing to do. I'm using our regular trocars, which I'm so used to in VR setup. After that, mark the meridians 180 degree apart, and I'm trying to open up the conjunctiva here. There is a large section over there. I'm trying to avoid that and trying to create a fresh one as much as possible. So tunnel creation is extremely important for XNET. XNET stands for extraocular needle guided aptic insertion technique, which I will be demonstrating shortly. So these side pockets are important because the needle has to come through that. So and open it. I'm sure all of you are good anti-segment surgeons here except me. So this is XNET device, the green thing what you see there. Enter, make the sclerotomy, go inside with a long customized 26 gauge needle. Once the needle tip is inside, that is a silicone stopper, dual protection silicone stopper. It temporarily holds the exteriorized leading aptic, which you will be seeing shortly. Use your McPherson forceps and gently depress the scleral lip, as you can see here, and try to make a sweeping sort of a motion. Once you complete the arc, it's like an arc. Once you complete, the tip is outside. Remember, do not try to penetrate the tissue, penetrate and come out, and simply dock the aptic of a 3-piece IOL into the lumen of 26 gauge needle. Around 2 to 3 mm of docking should be fine. Once you are good, try to retract the needle. At the same time, push the IOL inside. Do it, it should go as one unit. Retract, at the same time push it. You should not be separately retracting or pushing it, pushing the IOL separately. That's when probably the aptic-optic junction will become weaker, that you don't want it to happen. And remember, we have done something outside. We have done docking outside the eye, and we are not going to do anything inside the eye. And simply slide the dual protection silicone stopper close to the sclera and try to retrieve the aptic. Once you wait for the blue portion to be seen, hold it and disengage the needle. That's it. Single movement. Now the silicone stopper is on the aptic. You don't have to be dependent on the assisting nurse who may not follow you closely always. So when you're going to concentrate on the trailing aptic now, do the same maneuvers. Sclerotomy, these 180 degree sclerotomy, sclerotomies are extremely critical to have a good centration. So bring the needle tip out by sweeping motion. Retrieve the trailing aptic, just retract and push it inside. Yes. It has gone inside now. Again 2 to 3 mm of docking. Do it. So remember, when you do this step, the tip of the aptic should be facing down and the needle should be receiving it. Then retract the needle. Again, wait for the aptic to be seen. Once you see the blue portion, the aptic, you hold it and gently retract the needle. This XNIT device is exclusively done for SFIL, developed in collaboration with Aurolab. Now I'm introducing another device called S-Fix, stands for suture guided haptic fixation. It has 3 parts. The yellow portion what you see is a polyamide tube. You can see the full device picture over there in the inside. Dock the haptic, push it inside, push, that's the second step, push it inside till the complete polyamide tube is inside the eye. Then take a simple suture bite. Again, we are not doing anything intraocular. Suture and needle are something, as ophthalmologists we are so used to. So as an anterior segment surgeon, I'm sure you will be able to do this. Take a suture bite. Around 2 mm should be fine. Don't take a long bite over there at partial thickness sclera. So once you are done with this suture bite, retrieve it. Keep pulling. Retrieve the needle. The needle is out. Suture is out. Keep retracting the nylon suture. The polyamide tube comes out. Again, you will see that, but the haptic doesn't come out, it stays over there. It gets fixed inside the 380 micron, that's a suture needle size. The sleek suture needle track that you have created, the haptic is inside there. I'm repeating it on the other side. You will see that's a polyamide tube, which we have incorporated into the regular 380 micron suture with 5/0 nylon suture. So dock it, that's the first step, and push it inside, that's the second step. When you push till the entire polyamide tube is inside the eye, because the polyamide tube is not very flexible, so you need to ensure that it goes inside. The nylon suture is flexible. You can bend it, maneuver it, and take a suture bite, start from the point of sclerotomy and traverse for around 2 mm and come out. In case when you are, probably as a beginner when you are doing initial cases, you can always open the conjunctiva. In case if there is excess chemosis, again you can open the conjunctiva, visualize it comfortably. But I'm sure after that you won't probably need it. Retract the suture, thread. As you can see here, the thread comes out. Polyamide tube will also come out, but the suture gets fixed. You'll see that shortly. You can see the IOL movement of the optic inside, put retro and then visualize. Be convinced that the optic goes inside and the suture, you can see the blue optic gets fixed inside. Sometimes you will get to see this another, this is second case where I have done, handshake technique to, it's a clear corneal SFIL, clear foldable SFIL. I've done handshake technique to exteriorize the optics. I'm still using S-Fix. So as you can clearly see, you don't need to open the conjunctiva, there's no need for peritomy, there's no need for flap, no need for glue, no need for flange. All you need is a S-Fix device. Dock it, push it, and take a suture bite, starting from the point of sclerotomy. And again, reiterating that in esophageal surgeries, if you want good IOL centration, there are 2 things that are important. One is the sclerotomy points that you make, which should be 180 degree apart and equidistant from limbus, either 1.5 or 2 mm, but it should be symmetrical on either sides. And then how symmetrical the haptics are placed. So these are the 2 points that are extremely important to get good IOL centration, whatever be the technique. So now you can see the suture bite is done, and you retrieve it. S-Fix has, so as you can see, S-Fix has 3 components. One is 380 microns spatulated needle connected to a 5/0 nylon suture, and we have incorporated polyamide tube, 8 mm polyamide tube. So some amount of haptic, sometimes you will see it's actually good. You can actually push it inside. You can take advantage out of it. You can push, pull, and center the IOL at the end. So as you can see here, I am pushing it. Go to the other side, dock it. So remember, when you are doing this docking, there is a little bit of learning curve over there. Use 2 McPherson. Do not hold the hollow portion of the polyamide tube. You can see the polyamide tube, 8 mm polyamide tube we have provided. There are 2 components. One is suture fill, 4 mm, and suture free, hollow portion. Do not touch the hollow portion. I am touching the haptic and with the other McPherson, I'm touching the suture-filled polyamide tube, because the polyamide tube can get kinked. Yeah. So push it inside after docking. Do not worry about the IOL, it's not going to fall, because the aptics are, as you know, it's a curved thing and the polyamide tube is straight. So when you try to push the curved thing into a straight thing, it gets snugly fit. Also the dimensions are meticulously designed in such a way that this disengagement will never happen when it is inside the eye. Suture bite and retrieve. So remember, the suture bite has to start from the point of sclerotomy and traverse around 2 mm. It should be good. Don't take a long bite. That's when the aptic tip will get missed somewhere inside. Then you will find difficulties in centration. So I prefer to take a short bite, so that I would intentionally want the aptic tip to be seen outside for me, outside the conjunctiva, and then at the end I can sort of push it inside and tighten the IOL for good centration. Yeah. Thank you. I just want all of you to question yourself whether you can repeat the surgery when you go back home. I'm sure the answer is going to be yes. Thank you.
Thank you, Dr. Prabhu. So now you know why he's an innovator. So this is his innovation, and he's always seeing how to make this technique more user-friendly, and anyone can can think of doing a steel fixation. So congratulations. I think there'll be more people who will be willing to use this. So we'll take the questions towards the end. We have one last talk, Dr. Vivekanandan, on the iris fixation technique.
Thank you, madam. So good morning, everybody. Today is a very proud day because I'm sharing the stage with two of my teachers, Shivakumar sir and Haripriya madam. So I'll be talking on the alternative techniques, the iris claw, iris fixation, and my own flange technique of SFI. So madam has covered all this. In a PCR, when you have a small pupil and vitreous disturbance, it's always better to use iris hooks to visualize if there is enough capsular support before you decide what kind of technique you are going to do. So once you have enough support, you place it in the sulcus, but once you don't have support, there comes the other alternative techniques like the iris suturing. So the indications: insufficient capsular support, primary IOL opacification, where you have to remove the entire bag. You can do it as a primary and secondary procedure as well. The contraindications for any iris related techniques like the iris claw, this is any uveitis histories, multiple sphincterotomies, atrophic iris, corneas with hazy views, it is better to avoid these techniques. So coming to the surgical technique of iris fixation, so this is a single haptic fixation where you can see the image describes there is partial capsular support. The other side, you can fix it to the iris, and the side where the support is there, you can leave the haptic in the sulcus. So this is a long curved needle attached to a 10-0 or 9-0 Prolene suture. So you take the bite at the periphery, at the limbus, so that the needle passes through in the mid periphery of the iris. And this is a little bit blind procedure. Since the needle is curved, a small twist of your arm practice in the wet lab will give you that it reaches the other side through the limbus outside. And then the next step is always after you are taking the bite, make a paracentesis right in between the two suture points. Make sure you do not cut the suture while doing this step. This mainly is to externalize the sutures at the end and tie the knots. So now you have a suture underneath the iris. So using a Kuglen's hook, a gentle tap is given on the iris and it is pulled outside through the sclerocorneal or clear corneal incision. You can see the loop coming out of the eye, following which a 3-piece PMMA or 3-piece acrylic lens, whichever. I wouldn't prefer using a foldable single-piece intraocular lens. Any PMMA lens or a 3-piece acrylic lens will be the ideal lens to do. So here what we do is we loop the same around the haptics couple of times, 5-6 times, and then make sure you pull the loops all to the optic haptic junction. If you do not do that while placing the IOL, there is a high chance that the loops will slip and the IOL might drop. So once the loops are tightly anchored at the optic haptic junction, the right side haptic where the capsular support is there, it is placed in the sulcus, and simultaneously the trailing haptic is not dialed. It's a very important point. When you dial, what happens is the loops tend to slip away and fall down. So always pronate the haptic, release it underneath, and simultaneously pulling the suture which is closer to the optic haptic junction, which is coming out of the eye. That will anchor the loops at the optic haptic junction very tightly. So now that the IOL is positioned inside, what we have to do is trim the suture on the exterior which is coming out of the limbus trim it, interiorize it by using a spatula or Kuglen's hook. Once both the sutures are in the anterior chamber, we have a common paracentesis in the middle. So you bring both the sutures through the common paracentesis. So the instrument we need to do this is Kuglen's hook is very important. You cannot use a Sinski or anything. It's always important to have a Kuglen's hook. So once both the sutures are there, you tie 3, 2, 1. And how do you tie the suture is you do not crush the iris tissue. The iris tissue in between the two suture areas are going to be loose. So at the end of surgery, you will see a small parabola of the suture. If you are going to crush the iris tissue, you are going to have a very tight suture. What is going to happen is you are going to have tilting of the intraocular lens. We are trying to position the IOL at the PC level, no, as a regular in the bag positioning. So the IOL has to be a little bit loose for this to be there. So make sure if your iris is crushing, make sure you loosen it up. So this takes time. This is the couple of cases. The learning curve is a little longer for this technique for this one reason. The knots are placed and they are pushed inside. They are trimmed and pushed, following which viscoelastic is done. The other important point is always do your vitrectomy prior to placing the intraocular lens or taking the suture bite. These sutures are so thin. If you have a small vitreous strand at the end of surgery and try to do a vitrectomy, there are chances that you cut the suture and you have to repeat the entire procedure. So make sure you do a proper thorough anterior vitrectomy and then you go in for the iris fixation. And this is just another scenario where you have cases like this. You can do a double haptic fixation. Same thing. You use 2 curved needles on either side. Make sure they are 6 clock hours away from each other. You bring both the loops outside, and then both the haptics are anchored to the loops. They are positioned inside. The same procedure is done. So it can be done as a double haptic fixation also. The postoperative results are surprisingly nice. You have clear corneas. The postoperative, the positioning is not so close to the iris. It's a little bit posteriorly positioned. So iritis complaints are also very, very minimal. The advantage, like I said, all you need is just a 10-0 Prolene with a long curved needle. You don't need any specially designed intraocular lenses. The disadvantage is it's a complex procedure. The learning curve is steep. It takes a lot of cases to learn. Decentration and tilt can happen if the sutures are a little bit tighter. Coming to the next technique of iris claw. Preoperative workup, make sure the iris tissue is proper. In PCRs or in whole bag removals, when you're doing it as a primary and secondary procedure, make sure that the pupillary mobility is there, iris integrity, texture is there. Contraindications, where the prognosis is bad, endothelial cell count is less, inadequate iris tissue, and also in distorted pupils, patients with iridodonosis and iridotomy, so please avoid the iris claw lenses. It might be a very easy technique, but not in all patients do you give consistent results. So you can do anterior fixation and posterior fixation. It's always safer to have an anterior fixation. This technique, you require the iris claw lens, which is a special lens, PMMA lens, Clayman forceps, and a good anterior vitrectomy setup. So we'll just go into the surgical video. So this video is by Dr. Fatima madam. So once you have completed proper anterior vitrectomy, make sure you make the paracentesis exactly 6 clock hours away. Position the intraocular lens in the anterior chamber, the iris claw lens in the anterior chamber. Make sure you have enough viscoelastic. Using a Clayman's forceps, it is held very firmly, and then one haptic is introduced underneath the iris. Sometimes you might have to use a Kuglen's if the pupil is too small. Once one haptic is underneath, through the paracentesis on that side, use a spatula or a Sinski's hook to nudge the iris between the two claws. And then similarly, you have to switch hands to the left hand, hold the IOL properly, introduce it underneath the iris, and then nudge for the second fixation. And then do a proper viscoelastic wash and close the case. Outcomes can be like this in most of the cases. You'll have proper dilatation also, but it does not happen in all the cases. If this technique is proper, it can happen. The other complications and difficulties is bleeding, sometimes IOL drop, DM detachment. In traumatic cataracts where you have traumatic mydriasis, where you cannot place the intraocular lens, where the pupil is not constricting, this technique cannot be done. The other common thing is cat's eye pupil. On table you can see this happens when both the fixation are too close to the pupillary margin. When the iris tissue is too close, then probably you will have this complication. Postoperative complications include ovalization, disenclavation, dislocation, endothelial loss, cystoid macular edema. It's a little common in this technique. So it is a good alternative technique. It has a short learning curve, reduced surgical time. But the thing is, ideal case selection is very important. Proper technique is important, because once you enclave it in a wrong position or a little bit decentered, you have to cut that iris to remove the IOL tissue. So I'm not a big fan of the iris claw. I will just show you last what I do right now. So in PCR cases as a primary and secondary procedure. So this is the after cataract extraction, after anterior vitrectomy. I use a long spatulated needle which is 150 microns, which is attached to a 70 Prolene suture. 6 clock hours apart, 1.5 to 2 millimeter depending upon the axial length. The sclerotomies are done and both the needles are exteriorized through the sclerocorneal tunnel. I use a PMMA lens, single piece or 3 piece. The sutures are passed from above to below. The needles are trimmed and flanged, and the IOL is introduced into the eye. Once it is introduced, mild decentration is done towards the first site of flanging. The suture is trimmed to about 1 millimeter. It is flanged, and to bury it, the opposite side suture is pulled while simultaneously lifting the conjunctiva antenons. Now you can see that one side is flanged and buried. The second side, make sure you hold the forceps indenting the sclera a little bit, trim, flange, and then conjunctival closure is done. Thank you very much.
See this long one with curved, this one Oralab makes the long curved needle?
Yes, sir.
Oralab makes.
Yes.
Thank you, Dr. Vivekanandan. I think excellent display of techniques and pros and cons of iris fixation and the sterile fixation. We learned some new techniques today. We started at 10:10, so we have another 15 minutes to go for this course. So the audience, if you have any questions, we can take that now. The post-op medications. Yeah. So the one thing we normally do for all post-op capsule rupture, because of high risk of cystoid macular edema, we would add an NSAID for sure. So any NSAID, Depafenac, Ketorolac, we would give it for 1 month or 6 weeks. That's one thing we would add. If there's a lot of manipulation, I also add a course of oral antibiotics for about 3 days, just as prophylaxis. Though we don't have any strong evidence, we just do that when there's a lot of manipulation. For all eyes with lot of manipulation. If it's a small PCR, no vitreous loss, it does not matter. Besides that, the medication strategy would be the same, no change. As in all patients, we do give intracameral moxifloxacin on the table at the end of surgery. We give a little higher dose when we have a PC rent. So normally the antibiotic in the eye, like we use Oromox, in 0.1 ml, it has 500 mcg which goes into the eye. But if you're going to go in a patient, like now to get 500 microgram, we give about 600 microgram, which is 0.12 ml. In a PC rent eye, I would give 0.15 ml of the Oromox or Vigamox or whatever you're using. This way you have 750 mcg of the drug going into the eye. So 750, not all of it goes in, because as you're injecting you lose some. So stepping up a little more is still fine and safe, because we know that in PC rent eyes you do have chance of endophthalmitis. Besides this, we continue with a normal regimen of steroid and antibiotic for the post-op, but in case post-op you find that the patient has more inflammation, do step up, which we'll only know in the post-op period. Other thing is to manage the IOP. So we don't give any Diamox or any AGM prophylactic, because sometimes you also can have hypotony in these PC rent. The wound, if it's not been done well, if you have extended the wound or too much of vitrectomy, you can also have hypotony. So only in the post-op period decide if the IOP is high, then you may have to add an AGM. If it is low, obviously you'll want to patch the eye and see, if not take the patient up for suturing. But important end of the case to ensure the wound is well closed. If it has been extended or too much of maneuvering has happened, place one suture. Leave the globe watertight in a patient, more so in a patient who has a complication.
See, most of the cases, some visco will be left behind the IOL and in the anterivitreous area. So, if you don't see the patient more frequently initial days, you may miss this IOP spike. So, I blanket give and anti-glaucoma medication drop for all these patients for the first one week. I see next day, even if the IOP is controlled, I give it for a week and then stop, because some IOP spike is possible. And also, we without knowing would have sometimes dropped some thicker epinucleus bit or a bit of nucleus bit and all those, so it may just disappear without we noticing. So after a while, a dilated examination will be a good idea by the retina specialist, especially to check for this and also for the periphery of your retina. So some traction we would have created by pulling on the tags of vitreous or something. So retina examination is mandatory early, not too late, not too early also.
I think because most of us inject triamcinolone during the procedure to cut the vitreous, it has some amount of anti-inflammatory effect, but at the same time, if too much is injected, that's also very important. If you put too much and everything is going to go into the vitreous, then again that can cause an IOP spike. So you should know exactly when to put the triamcinolone. It should not be too much, but at the same time it should help you to dilate the vitreous.
Is it a mic somewhere?
I just would like to know, in cases where manual vitrectomy is done, just small strands are done, what I recommend the residents to do is at the end of surgery, post-operatively for a couple of days, tablet Dimox half BD for 3 days, just to keep the vitreous condensed and pull this thing. Is that a practice?
I don't do it. Like I said, I see the patient post-op and then decide, because you've also had instances of hypotony, so I don't give. So on first day post-op, if cornea is clear, everything looks quiet, I don't add an AGM. If there is an IOP spike or there is some epithelial edema, then I agree. I think, but most patients, as Dr. Minu and other speakers agree, there is a very high chance of having an IOP spike in eyes with complications. So that is very important for us to manage it, especially if we've had retained lens matter. And there can be some amount of cortex left behind in the bag or in the vitreous, and there is a chance to have an IOP spike. So you can see these patients, if possible, frequently, at least 1 day and 1 week, just to have an idea there's any IOP spike or inflammation has increased. For these two reasons, you may have to see them more frequently.
Actually, the other reason for the IOP spikes is the amount of residual viscoelastics into the vitreous. So that's another reason. That's especially seen in post-iris law IOLs where the entire thing is sealed off. So whenever you are injecting viscoelastic, especially in the hypotonous eye with the vitreous come out, a lot of visco gets accumulated. And after the iris law IOL or chasing an IOL, if adequate vitrectomy is not done under the IOL and the visco is not removed like it was shown in some of the clips, you may have the IOP spikes with or without with cortex getting blocked inside. So whenever you have got a prolonged spike of IOP, which doesn't usually settle within 1 or 2 days, you should suspect that it's either due to residual cortex, residual visco, or both together.
Yeah, next question, please.
What is your take on pars plana vitrectomy for all the cases where there is vitreous loss?
Yeah, so I personally don't think it is necessary. So you can do an anterior vitrectomy. In my personal opinion, I think it is safe, but we'll have to remember the principles of vitrectomy. So you can't give traction on the vitreous base. So you will, but if one does, an approach to pars plana, that's probably a very good way to approach, but it's not mandatory, I feel. You can do an equally good job through the anterior route as well, through the limbal route as well, but use those principles. Have your incisions the right size for your probe to be introduced. Make sure that you always go by manual. Ensure you cut the vitreous completely. Like I said, have the cutter. So you try to avoid the rise of the vitreous to come towards the probe. It comes like a slinky toy. Rather, if you can have the cutter facing down, you cut and it goes home. Don't move the cutter too much when you are in the cutting mode. Do the movement more when you are in the in the aspiration mode. So having those principles in mind, I think anterior route to me works as well. And I've always been doing anterior approach.
I just want to add a point. In case if you are deciding, the midway, if you are deciding to go for a pars plana approach, See, remember you have started vitrectomy and the globe is hypotenuse to some extent. So never make a pars plana entry in an hypotenuse globe. So you always form the chamber and then do it. If you don't follow that principle, what can happen is when you are trying to push the pars plana trocar inside, choroid can also go along with that. So you will end up causing a choroidal detachment when you are making a port. That's something you don't want to have.
All these complicated cases, chances of endophthalmitis, CME, and high intraocular pressure is very high. So I think the patient has to be counseled to come to post-operative follow-up on time, because sometimes these patients come with a pressure of 50, 60, and it will kill the nerve in about a week's time. So that's very important. Post-operative follow-up, a very close post-operative follow-up is very important.
And also, to be tactful in private practice, you should not make it very obvious that you are being treated differently. The patient who had a PCRN is being called more frequently and is being tested by multiple people and all those. So that will make people more suspicious something has gone wrong. So you can always tell that there is some inflammation or IOP spike or something which needs to be monitored, and they should not be placed along with other patient. I usually mark on the case sheet with the color, red color, and then when they come, they are routed separately, and they come go to the vision area and then come into my room fast without waiting in a different area. Then otherwise they will which day did you get operated? Okay, 1 week later. Oh, I am called third time now. No. So that is all to console the patient and also make things smooth for you. You would have done a very good job in this, but then they will realize that something gone wrong, and then that will be in their mind and attribute all the other irritation, watering, all those symptoms to something which has happened which has no connection to it.
So as regards the pars plana vitrectomy, Madam clearly mentioned that it has a role to play when there is a constant prolapse in cases of PCR. But I think I've heard experts saying that for a zonular dialysis, that's the best thing to do. Because with an anterior vitrectomy, you are constantly pulling the vitreous across the bag, over the bag, and it may not settle down under the bag if you're not doing a good vitrectomy. So the better one is to go pars plana and do it under the bag, and then it settles down much easier than an anterior vitrectomy. So I think pars plana has got a place there.
I'd just like to add on to what Dr. Minu says. He brought up another very important topic on patient communication once you have a complication. So this is again a very sensitive, very difficult thing, and I think a surgeon matures fast enough to handle a complication, but to handle a patient is a different ball game. So it's important for us to do that. And how and when do we communicate is a different thing. But as Dr. Minu said, you'll have to be sensitive, you'll have to be open, but if it's a small rent, everything has gone fine, you don't have to go and complicate things. But if you have changed the IOL or you have any retained lens matter or the patient obviously needs a reoperation, do not hesitate to open up and tell the patient that yes, that the lens we intended to place was not, was not possible. We have changed the IOL design model, whatever, because the support was inadequate, and this is the reason, and we will ensure that you give care. So that transparency is important, but not to overly, make them tell them all if you had a rent and everything is fine. You don't have to go and confuse them, because they will obviously get a little more concerned in those instances. Any other comments or final questions?
And the time taken during surgery also. So generally, sometimes they would have done other eye surgery and it would have finished in 7 minutes, and this would take 25 minutes, and then they will definitely keep watching. People under a drape, they are always listening to things happening and all those. They are aware of all these things. So that also, please mention while it is going on. If it is topical, they'll start getting pain. So please add on paracaine or intracameral lignocaine, and tell patient that this is little too hard, or your machine has to be restarted or something, and it is taking a little time. So tell even bystanders also. They will also feel that he has gone 1 hour back and now he is not at all seen outside and all. So all those has to be communicated in a very careful. You should not be letting your postgraduate go and tell. Postgraduates do, or even nurses and all, they don't realize the thing. They will tell something they are not sensitive. So handle with care how you deal with patients and bystanders when you have these kind of altered surgical, intraoperative, inside the theatre and post-operative regime.
I think we'll have this last question before we close. Yes.
Peripheral iridectomy is required in cases of iris claw lens.
You have to, iris claw you'll have to, iris fixation you don't need, but iris claw yes. So I think if there are no other questions, I think we are reached our allotted time. So I'd like to sincerely thank all the speakers who did a fabulous job. I really learned a lot. Thank you, and thank you all of you for taking the time to be present today. Thank you.